And a different model of care that the team here at Mass General has been interested in studying is more of a clinical model of care. Rather than provide palliative care over the telephone, when patients are coming into the clinic to see me or my colleagues and getting chemotherapy or getting radiation, could we actually have them see a palliative care doctor or nurse here in the clinic at the same time and see if this integrated or co-management model would help patients and their families? So we also performed a randomized study where patients with newly diagnosed advanced lung cancer were enrolled and then coin flipped or randomized to different strategies. One of that strategy was that patients would start seeing the palliative care team right after diagnosis, and the palliative care team would follow them throughout their illness. The second strategy was that they would only be referred to palliative care when the patient's family or oncologist felt that they had symptoms or care needs that weren't being addressed. In our study, the palliative care was provided by physicians or advanced practice nurses. As I mentioned, this was somewhat of a co-management model. So while the patients were receiving their chemotherapy or also seeing their oncologist, they were seen by the palliative care provider. The palliative care providers were permitted to focus on whatever was important to the patient and their family. And if patients were admitted to the hospital, they were also followed by the palliative care team. I'm going to run through some of these data slides quickly, but one of the most important findings of this study was that patients who were receiving this early palliative care model had significantly improved quality of life. For those of you who aren't familiar with quality of life, it's sort of a measure of how up and about someone can be, how functional they are, how well their symptoms are controlled, how much they're enjoying time with friends and family. So again, the previous study and this study showed that involving a focus on palliative care significantly improves quality of life and symptoms in patients with advanced cancer. Also, patients who were receiving early palliative care had significantly lower rates of depression, so their mood was better because of the involvement of the palliative care team. And again, some of these very important issues that we talked about earlier about illness and prognostic understanding and how it impacts decision-making, patients who were receiving this early palliative care intervention were significantly more likely to understand their prognosis. They were more likely to participate in conversations about their doctors, about their preferences for care when they were ill. And very important, they were more likely to be referred to hospice in a timely fashion, which again has been clearly shown in the literature to be very important for patients and families when they're at the end of life. So this is another one of those survival curves, and again, like the previous study I showed you, raised a question of if we provide more palliative care, more support, more symptom management for patients and families, can it actually have an impact on their survival? So this was also very exciting data. I think there's still a lot of unanswered questions and uncertainty in this field, which is actually a fairly new field. Both studies I showed you demonstrated that palliative care improved quality of life and patients had lower rates of depression. And exactly why that is actually a bit unclear. Many facilities have only one or two palliative care physicians and nurses. Unfortunately, many areas we don't have any palliative care providers. So what's the appropriate dose of palliative care? How do we get patients access to these services that they need? The third point on this slide is a very important issue that many big organizations such as the American Society of Clinical Oncology are really focusing on now. So I think we all believe this data, that palliative care improves quality of life and improves outcomes, but we know that there's not enough palliative care providers around the nation and around the world for everyone to see them. So can we sort of distill what the palliative care providers are doing and then teach it to oncologists so the oncologists can change their behavior and adopt some of these palliative care practices so that all patients who have cancer can achieve these results of better outcomes due to their oncologist providing palliative care. Obviously, we talked about that a cancer diagnosis such as lung cancer doesn't just impact the patient, but it also impacts their families. And we need some more data on how early palliative care or more intensive palliative care helps family members who are still often neglected as the patient's going through their cancer care. And then the last question, which I think is probably less relevant to us as care providers and patients and families, but is early palliative care cost effective? It is a very important question for Washington, because if we want the government to make healthcare policy changes to have palliative care be more supported in hospitals, at academic centers, and clinics, then we do need to demonstrate that it's a cost-effective model of care. So what are the take-home messages for those of you on the phone? Number one, cancer is really hard for patients who are diagnosed with it and the people who care for it. And we all obviously want to be strong and fight our cancer and have a good attitude, but every once in a while you just have to remember that it's really, really hard, and it's okay to ask for help. It's okay to admit that things aren't going well, you're having symptoms that aren't being well controlled, and that you need an extra layer of care. And it's important to remember that clinicians can do things to improve patients' and families' experience with cancer that go beyond providing chemotherapy. We can think about different types of support from social workers, from psychologists. We can add medications for fatigue, for cough, for pain, to try to make things better for patients. In addition, a greater focus on managing these physical and psychological symptoms and engaging patients and families in discussions about their prognosis, about patients' preferences for care, can have a meaningful impact on patients' life and care, and again, maybe even their survival, which is obviously an incredibly important measure.